Good afternoon, gentlemen. Terribly sorry to impinge on the next talk, but I'll just make it short and sweet. Hopefully, it'll be short and sweet. So here we are talking about something post-refractive surgery dial power calculation, which can be alternatively called as biometry from hell. This is so difficult sometimes that I know certain surgeons in Delhi who refuse to operate on post-refractive surgeries in the sense that they will not get a proper IOL placement. So it doesn't need to be as bad as that. So let's talk about the three problems that we have. Why is this such a big problem? The first problem is instrument error. We'll discuss this in a second. Keratometric index error and the formula error. Okay? It's important to understand that instrument error is because you see we use keratometers which measure the paracentral cornea, not the central cornea. So 2.5 to 3.2 according to the instrument. So what we measure is the paracentral area, and after refractive surgery it misses out the central area, which is flat, isn't it? So we're measuring basically the paracentral and we are missing the flatter zone in the center. This adds up to 15% of overestimation because of the steep paramedian. So that's quite a lot. Okay, that's one. And second is the number two, index error. Index error has been talked about. See, the refractive index of the cornea is 1.376, but keratometry assumes it's 1.3375. Why is that? Because it makes life simpler, because it converts a 7.5 millimeter radius into a 45 diopter. You know that we cannot calculate the IOL power, the corneal power directly. We have to calculate from the radius. So if I take a 7.5 millimeter radius, it gives me a 45, so which is this assumption. But this assumption is based on the fact that the back to front ratio is 88%. You know that the posterior corneal curvature is more curved, is it not? So we take that ratio, radius curve is 6.8 divided by 7.7. This is the 88% is the normal ratio in a virginal cornea, but this changes when we do refractive surgery. The 88% after myopic becomes 68%, and after hyperopic glasses becomes 90%. So we cannot hold this assumption. With the result, we'll end up with index error. So these two errors, how do we solve that? We solved it. Look at that, 15% and 10%, 25% error in keratometry. So the only way to solve this is to do it directly. Okay, so we do direct measurements, anterior and posterior corneal curve, which is how to do that. We do these topographers and like Pentacam, OBSCAN 2 or OCT, whatever is available. The nowadays standard of care is Pentacam with its Schindler camera. In 2 seconds, it captures 25,000 points, and because it has single fixed meridian, so in the 2 seconds that it needs to capture, if there is a movement of the eye, that error can be minimized. So this is nowadays the instrument of choice for most of us, where we use a Pentacam. And so let's look at that. So what we do, amongst the many maps, we pick up the holiday report. Remember, the Pentacam comes inbuilt. There's a default setting of holiday, and my advice is not to change it, not to tamper with it. And we pick up this map, which is called the EKR, equivalent K reading. What it does, it measures the central corneal powers across various diameters from 1 to 7 millimeters of the cornea. Okay, so you can see from 1 millimeter to 7 millimeters, you have a choice, but the EKR 4.5 is the best for central corneal power. Reason being that if it's less than 4 millimeter, you exclude too much of the pupil, and if it's more than 5, then the Stiles-Crawford effects with the directional sensitivity may cause an error. So best is to take the EKR 4.5 zone. You get your keratometry. The third error we have not yet taken into account, and that is the ELP. Remember, ELP, as mentioned by the previous speakers, is the most difficult. It's the holy grail. The effective position of the postoperative IOL is the most difficult to measure. And the third generation formulas, usually, which is called the American formula, all the Hoffer-Q, holidays, SRKT, they predict the ELP via a combination of axial length and keratometer. And this makes a false assumption, because now it's a flatter K. A flatter K would assume a shallow RACI and estimates ELP more anteriorly, but this is not true, as just Dr. Gisline told us. So this is not true, because actually there's no change in the position of the ELP. It remains the same. So this is another error introduced, and to neutralize this error, we have a double K method of Aramberry, where we use 2 different Ks. Okay, the first K is for measuring the ELP, and the second K is for IOL power calculation. And if all the formulas that the Americans, as I said, they have to include this correction, otherwise we cannot go ahead with the calculation power. And let me give an example. If you don't know what happens, see, if you use a preoperative K of 45 and a post-refractive keratometry of 36, a normal standard refractive surgery, IOL 24.5, and now you want to implant an IOL of 18.9. With the holiday one, aiming for emetropia, we get a 26.6, no double K. However, with the double K correction, we get 29.37, which leads to about 3 diopters hypermetropia, which is 6 less than 6 by 60 next day, okay? Because there's no accommodation anyway. So that leads to a very unhappy patient. So what happens? So therefore, what do we do? So we have, let me tell you one important trivial question. You know, number of formulae published for IL power for refractive surgery, we have almost 36. And at the time of speaking, there's some more going into press. So how do I take formula? The simplest thing I have to advise you is to go to the online calculators, freely available on SCRS. You can have iLabs and have APACRS. The most popular is usually the ASCRS. It's completely free. All you do is to go to the website, fill up the details like this. It's very clear, there's no doubt about it, and press calculate. Very simple. We press calculate. It takes an average of 7 to 8 different formulas and presents us with an IOL which you can choose. Let me give an example. A pre-LASIK refraction of minus 11, a post-LASIK of minus 2.2. Many of us, we deal with this kind of refractions. Pre-LASIK aerometer is 42, but post is 36. And axial length of 28, AC depth of 3.5. And see how we apply this. And this is the IOL power, the online calculators. You don't have to do this. Correct corneal power is not the refractive correction, but at the corneal level is not 11.25, it's 9.91, applying various formulas. Post LASIK is 2.9, not 2.25, but 2.91. So we have a difference of 7.72 at the corneal level. So that's completely different. And the corrected K is 42 minus 7.72, which is 34.2, which is not the same as 36, which was assumed before. And with this, we get an IOL power all calculated by multiple formulas by the online calculators of 20.6, one group of formulas by Sharma's, 20.4, 20.8 by Haggis, 20.6. We take an average of 20.62, final 21, and we'll end up with an amazing refraction of only post of minus 0.5 cylinder at night. Astonishing, but true. So this is the latest standard of care. RK is another problem. RK problem is that you see both surfaces flatten. In eczema, only the anti-surface flattens, not the posterior. But both surfaces flatten RK, but not equally. The posterior surface flattens more, about 33%, anti-surface only 22%. And that causes another element because the optical zone is smaller here, 3 millimeters. So instrument error is more likely. Okay? Again, we do the same thing, estimate the corneal power, fill up the formulae. And if you don't do that, look at what a case report published recently, 43-year-old male with a left eye cataract. RK done 17 years back for minus 11 and 8 cuts RK. Pre-op refraction with the minus 2.5 with the minus 4. This is before with the cataract. And K1 52.1, K2 38.5, Axon 30.5. Remember, he's minus 11. IOL power with SRKT was 1.5. The surgeon wanted to be on the conservative side, so he implanted 3 times. He implanted 5 diopters, and yet the refraction comes out to be plus 12 with the minus. That's incredible, and you know what is going to happen next. So my friends, again, I must insist that we go back to the IOL calculator, fill up the details, and what are the take-home points therefore? Patient has to be told about unrealistic about his expectations. We estimate the alpha, we do not calculate it in this case, in this post-refractive. IOL has to be checked with multiple formulae. No single formula is the best, except the Barrett's 2K is coming out a little better. And when in doubt, always choose the higher IOL power and avoid multifocals like the plague. Thank you very much. And any questions are welcome.